So our next speaker is Dr. Anuja Patil, and she is having a mysterious case of unilateral disc edema.
Good afternoon. I'm going to present a mysterious case of unilateral disc edema. So, this case is of a 40-year-old female who presented with blurring of vision in the right eye from 6 months, which was associated with mild pain in the right eye and headache. She is a known case of diabetes and hypertension from 2018 and was diagnosed as right eye posterior scleritis in May 2022, for which she took a short course of oral steroid but had to discontinue it because of uncontrolled blood sugar. So when she presented to us in December 2022, her best corrected visual acuity in the right eye was 660 and it was 66 in the left eye. The right eye showed presence of pigments on corneal endothelium and had sluggishly reacting pupil to light. Rest of the anterior segment findings of both right and left eye was within normal limits. Now, if we see the fundus, the left eye fundus findings were completely within normal limit. Now, if we see the right eye, there was a vitritis of grade 1 plus with disc edema of Friesen scale 5 with inferior disc hemorrhage and a partial macular star. The periphery was within normal limit. We did right eye OCT macula, which showed presence of vitreous cells, and there was cystoid macular edema in the nasal fovea with presence of subfoveal fluid, and there was also the choroid appeared thickened, and there was bumpy appearance of the choroid. The left eye OCT appeared normal. We also did right eye ultrasound B scan, which showed presence of retinochoroidal scleral thickness of 2.1 millimeter, which was a little high, and there was a small fluid pocket inferior to the disc, but there was no T sign which was noted. So based on this, we made a differential diagnosis of neuroretinitis, posterior scleritis, ocular sarcoid, atypical VKH, and atypical optic neuritis. Neuro-ophthalmologist consult was taken, and based on that we empirically started her on tablet doxycycline 100 mg BD, and we plan to start oral steroid after ruling out infective etiology. So the systemic investigation showed negative Lyme serology, MON2 test was negative, TB quantiferon gold was negative, ANA, ACE, RPR, TPHA, HIV was all negative and non-reactive. We also did CE, MRI, brain and optic nerve, which showed presence of an extradural meningioma, which was not related to optic nerve. So on third day follow-up on doxycycline, the visual acuity did not improve. The fundus also did not improve. Rather, the right eye OCT scan showed deterioration with increase in the vitreous cells and multiple fluid pockets with the increased bumpiness of the choroid. We also did FFA, which showed the right eye FFA showed disc leakage with multiple pinpoint hyperfluorescent spot and inferior disc pulling in the late phase. Left eye also showed similar multiple pinpoint hyperfluorescent spots. So based on OCT and FFA finding, we made a diagnosis of atypical VKH, and we started the patient on Vizthelon 45 mg OD and tablet Azuran 50 mg OD after seeking endocrinologist and rheumatologist consult. So on these medications, she improved to 618 in the right eye, and her fundus also improved. The disc edema was resolving, and the OCT also showed decrease in the vitreous cells with complete resolution of subfoveal SRF as well as intraretinal fluid. The bumpiness of choroid has also decreased. So this is how the patient improved on oral steroid and immunosuppressant. So this was the last follow-up, which was in the month of March, on which she had right eye visual acuity of 618 with complete resolution of intraretinal and subretinal fluid with improvement in the bumpiness of the choroid. There are few case reports wherein the VKH has presented as unilateral neuroretinitis. So VKH should be considered as a differential diagnosis for chronic recurrent idiopathic neuroretinitis cases, and in such case we should always go for ICGA and FFA to rule it out. Thank you.
In such cases, the OCT of both eyes as well as the ultrasonography of both eyes is important. And the other eye, which doesn't show VKH, may have choroidal thickening or on SSOCT or EDI OCT or ultrasonography. So So we have reported some cases of unilateral leakage, but they had some choroidal changes in the other eye. And these patients may after some time develop
Yes.
leakage, full-blown leakage
In the other eye.
in other eye.